The House Oversight Subcommittee on Public Health and Food Security will come to order. Would the clerk please take the attendance?
Chair Beerline.
Here.
Representatives Paquette, Green,
Present.
McDonald,
Present.
Cerniglu. Mr. Chair, you have a quorum.
Representative Green moves to approve the minutes of the March 10th meeting. Hearing no objection, they are approved. Good afternoon, everyone. Before we begin, I just want to take note, so we're going to go on break for a few weeks after this. So this is the final committee hearing we have focused on this topic of in-person pharmacies closures in Michigan for the time being. I want to sincerely thank everyone who has participated throughout this process. I appreciate those who have previously came before the committee to testify, those who are joining us today, and the many organizations, pharmacists, and stakeholders who took the time to reach out to my office to share their perspectives and experience on this issue. So with that, we will begin today's testimony with DIFS as they present on their Pharmacy Benefit Manager Transparency Report. So if you please come up to the table. I think you guys know the drill, and we'll get started.
Hi, I'm Jenny Geese, legislative liaison manager here at DIFS, and with me is my colleague.
Joseph Sullivan, the director of our Office of Innovation and Research.
And appreciate the opportunity to speak before the committee today with regards to pharmacy benefit managers. Just as a little bit of background on DIFS, DIFS ensures the safety and soundness of the state's insurance and financial service industries, and we are fee funded and we don't require tax dollars to operate. We stand here ready to serve as a resource to the legislature. And also just a little bit of historical background with regards to PBMs. So pharmacy benefit managers, PBMs, are playing an increasingly large role in the prescription drug supply chain. And many states have been grappling with addressing the high costs of healthcare. There has been a broad nationwide effort regarding the role of PBMs, and you have the National Association of Insurance Commissioners, which is our accrediting body, the National Council of Insurance Legislators, and other national groups have deliberated this issue, often through model laws or recommended policies. So additionally, Congress is currently grappling with this issue. In February of this year, Congress enacted several PBM-related provisions. With regards to here in Michigan has been working on the role of PBMs since the beginning of Governor Whitmer's administration. In 2020, Governor Whitmer signed Executive Order 2020-01, creating the Prescription Drug Task Force. The task force included the directors of MDHS, DIFS, LARA, and also 5 legislators that were bipartisan and bicameral. The task force was charged with a few things. One, analyzing the scope and causes of the problem of high-cost prescription drugs in Michigan and the impact this problem has had on the state's residents, communities, and businesses. Analyzing the way prescription drug prices are set in Michigan and identifying strategies for increasing the transparency of that process. Also recommending legislative and administrative actions and policy-related changes that can be implemented by governmental and non-governmental agencies relevant to lowering prescription drug prices for consumers in Michigan. And then lastly, recommending legislative and administrative actions that can be taken and policy-related changes that can be implemented also by governmental and non-governmental agencies relevant to increasing transparency in the pricing of prescription drugs in Michigan. The task force heard input from health policy experts and stakeholders to obtain an understanding of the factors that influence drug pricing and to discuss legislative and administrative solutions to lower the cost of prescription drugs for consumers. Regarding PBMs, the task force made policy recommendations that would provide cost savings as well as transparency and accountability to the system. In particular, it required PBM transparency reports, licensing PBMs, restricting the use of gag clauses in PBM contracts with pharmacies. And then in 2022, the legislature passed legislation that addressed some of these recommendations from the task force, which also included the PBM legislation. This oversees state-regulated insurance companies and now PBMs, but does not regulate other prescription drug supply chain actors like pharmacies or drug manufacturers. Public Act 11 of 2022 amended the insurance code to require PBMs operating in Michigan to be licensed by DIFs beginning January 1st, 2024. The law aimed to improve transparency and lower costs in the prescription drug market, though licensing PBMs to allow the state to exercise some regulatory control, requiring PBMs to submit annual transparency reports, prohibiting contract provisions such as gag clauses and spread pricing, and requiring fair pharmacy audits. Per statute, the PBM licensing application must contain the following information: organization documents with any amendments, a consent to service form for the PBM, information on the individuals in the organization who are responsible for the conduct of the affairs of the PBM, criteria to show financial viability or stability of the PBM, experience or expertise of officers, directors, and owners, or standards for the PBM as a whole that would make them qualified to act as a PBM, a document for the PBM to attest that their ongoing contracts comply with the Act, and the application fee. The director can also refuse to issue a license for a few reasons. The PBM is determined to not be financially viable. The PBM or an individual responsible for the PBM's affairs has had a PBM license denied or revoked for cause in another state, and also an insufficient license application. With regards to licensing renewals, PBMs must renew their license every 2 years, submitting the following 3 items: a renewal application, renewal fee, and also retail pharmacy network adequacy report. And to maintain a license, a PBM must comply with the following: all contracts must comply with the Act. The retail pharmacy network must be reasonably adequate and accessible. DIFs use its form and manner authority to require this part of the application. And then with regards to the DIF's regulatory actions, per statute, the department can engage in the following regulatory actions: issue cease and desist orders, deny license, suspend license, revoke license, restrict license. It can also investigate officers of the PBM, similar to insurers under the insurance code. They can suspend or restricted licensees can face up to $20,000 per month until the violation causing the suspension or restriction has been remedied. DIFs can allow the PBM continue providing services for 60 days on a restricted or suspended license for the benefit of the PBM's covered persons. If a PBM operates under a suspended license for more than 60 days, DIFs can revoke the license. And then also, a PBM has the same rights to notice and hearings that insurers have under the insurance code. And at this point, I'm going to hand it over to Joseph Sullivan.
Thank you. And I think that's helpful context to sort of demonstrate how we got to this point and what the department's responsibility is in all this. But I did want to detail what actually was in the PBM transparency report. There were several reporting requirements in the law. A lot of this is very complex. It's a lot of numbers, but I'm going to go through it and happy to answer questions in the end. So licensed PBMs are required to file an annual transparency report beginning in April of 2025, and that is an annual requirement, so they have to do that each year afterward. DIFs was then required to prepare an annual report beginning on August 1st of 2025, which we released successfully on that timeline last year. And this is based on specifically the PBM's transparency reports that they submit to us. All that information is purely just aggregated by the department and placed into the report. The report details specific items. It references statute for each item that's in the report. And it must not contain any information that DIFS determines would cause financial, competitive, or proprietary harm to the PBM or the carrier. All 37 PBMs that applied for Michigan licenses in 2024 and did not withdraw their applications submitted transparency reports, with 18 of those submissions claiming the PBM is exempt from all reporting requirements or having no information to report. For example, that could be if the PBM has no Michigan health plan clients or they're not doing any business. We did see some PBMs apply for licensure in the state before they started to do business, so that's an example of them being exempt per statute from reporting. So what's in the report? Per statute, again, it contained a list of the aggregate of the wholesale acquisition costs, also known as WAC, reported by PBMs from a manufacturer or wholesale distributor for each therapeutic category of drugs for the PBM's Michigan plan sponsors. This is net of rebates and other fees and payments, direct or indirect, from all sources. That is a very large table that's in the report. We did print that for members prior to the committee. The report is also available on our website for anyone who's curious. I did not plan to read through that entire list of drugs, but essentially that represents what the drug spend is for each of those categories. The report also detailed the aggregate amount of rebates that PBMs reported receiving from all manufacturers for their Michigan plan sponsors, including any utilization discounts they received from a manufacturer or wholesale distributor. This number was just under $2 billion. Rebates essentially represent a formulary discount attributable to the use of prescription drugs that is paid by a manufacturer or a third party, directly or indirectly, to a PBM after a claim has been adjudicated at a pharmacy. A rebate does not include a fee per statute. The aggregate amount of rebates that PBMs reported receiving from all manufacturers that were not passed through to the Michigan health plan or insurers was a little over $150 million. The aggregate retained rebate percentage reported by PBMs from business conducted in the state was at around 7.7%. The aggregate amount of all fees that PBMs reported receiving was about $140 million. And the aggregate amount of rebates and fees that the PBMs reported receiving from manufacturers attributable to patient use of prescription drugs covered by Michigan health plans that were passed through to Michigan health plans or enrollees at the point of sale of that prescription drug was again just under $2 billion, $1.8 billion. The aggregate amount of rebates and fees that PBMs reported receiving from manufacturers attributable to patient use of prescription drugs covered by Michigan health plans that were retained by PBMs, so this is the PBM's retention amount, was about $259 million. So regarding pharmacy benefit manager and health plan relations, there were several provisions that were in the law. A PBM must notify a health insurer of any activity, policy, or practice that they engage in that represents a conflict of interest. A PBM must not engage in spread pricing on a contract beginning on January 1st, 2028, or any contract established between the effective date of the act and January 1st of 2028. So spread pricing is essentially the practice of PBMs charging the health plan more than the amount that they pass on to the pharmacy and then keeping the difference. There were several provisions regarding the relations that PBM has to have with the pharmacy itself. Essentially, a PBM is prohibited from a category of provisions. The first is charging or holding a pharmacist or pharmacy responsible for a fee related to a claim not known by the pharmacy at the time of the claim's adjudication. There is a fraud exemption for that if anyone's curious. Also, they're prohibited from charging a pharmacy a fee for any step of the claims adjudication process. They're prohibited from entering into a contract containing a gag clause or a clause essentially that prohibits the pharmacy or pharmacist from discussing or providing information. This is typically the cost of the drug, the nature of the treatment, risks or alternatives, the availability of alternative therapies, consultations or tests, the decision of utilization reviewers or similar persons to authorize or deny services, and the process used to authorize or deny services or benefits. A PBM must also pay a pharmacy within 14 days after the adjudication of a claim if that claim is submitted electronically. This next part is pretty complicated and convoluted, but I'll detail provisions regarding maximum allowable cost. So the law had some provisions on this. MAC prices are the upper limits that a health plan will pay for a generic drug and brand drugs that have a generic alternative available. Generic drugs have a large range of average wholesale prices, and the MAC prices here are used to reconcile that difference between the inflated average and the price that the pharmacy actually pays. So for each drug a licensed PBM has established a MAC for, they must do all the following: provide each pharmacy subject to the MAC list with access to the list and the source used to determine the MAC for each drug, update the MAC list at least every 7 days, provide a process that allows for each pharmacy to be promptly notified when a MAC list is updated, and establish and maintain a reasonable administrative appeals process to allow a pharmacy to challenge a listed MAC. The PBM must investigate and resolve an appeal under this section with 14 calendar days after received. Within 14 calendar days, an appeal under this section must be submitted to the PBM not less than 45 calendar days after the date of the pharmacy's claim for reimbursement has been adjudicated. And then a response is in writing to the appealing pharmacy is required within 10 days. So essentially what all this is PBMs argue that the MAC lists ensure that their contracted pharmacies are encouraged to purchase less costly generics available on the market. And then the pharmacists have their own opinion on the MAC list and kind of position that it places the PBM in. There were several provisions in the law regarding fair pharmacy audits, so essentially how the PBMs can audit the pharmacies. A PBM must notify the pharmacy at least 2 weeks before beginning this audit. A PBM is limited to review 1 year of claims unless a longer period is allowed per state or federal law. A PBM is prohibited from paying the auditor a commission for audit findings. A PBM must establish an audit appeal process that meets certain criteria. A PBM may only recoup funds after a final audit report has been issued to a pharmacy, and a PBM is prohibited from doing an extrapolation audit to calculate recoupments, restoration, or penalties unless required by federal law. And a PBM can prove intent to claim fraud on the part of the pharmacy to recoup money from that pharmacy. And then just in general, there's several prohibited PBM business practices that were put in the law. They're prohibited from the following. So a retail pharmacy, they can't prohibit a retail pharmacy from delivering a prescription drug by mail or common carrier to a patient or caregiver. They can't prohibit requiring a pharmacy to maintain more stringent accreditation than is required by federal or state law, causing or knowingly permitting the use of an advertisement, promo, solicitation, representation, proposal, or offer that is untrue, deceptive, or misleading, reversing and resubmitting a claim without prior and proper notification, just cause, or after 90 days of the adjudication of that claim, failing to pay an adjudicated claim after termination of a contract with that pharmacy, or retaliating against a pharmacy for exercising their rights contained in the bill. And then more specifically, here's a few duties that are imposed on the department. So we had to promulgate rules to implement PBM licensure. This included a renewal fee, fine, suspension of licenses, restriction of licensure, and revocation of that license. We had to follow a specific record retention schedule set up in statute. This is essentially comparable to what's in the Third-Party Administrator Act. And the law allows DIFs to examine or audit a PBM's records and books, but all information received for examination must be considered proprietary and confidential. It's not subject to FOIA and can only be used to ensure compliance with this act. And as previously mentioned, DIFs is also required to prescribe a form for a PBM to apply for a waiver of network adequacy requirements, and then beginning in 2025, the transparency report that we noted. Another kind of unique nuance I wanted to mention was when this law was passed, there was a companion bill, Public Act 12 of 2022, that was also passed. So this is for the Third-Party Administrator Act. The provisions in there hold essentially the same obligations to the PBM, but now a PBM has to be licensed as a third-party administrator, which is essentially what they were prior to the law, and also as a PBM. So it's essentially a redundant requirement. And then just overall, I should note that there were several provisions that the pharmacies advocated for during the legislative process that passed the House in 2022. but that did not make it to the final version of the PBM law that was ultimately signed. So there were several differences and distinctions there. I did want to detail sort of the rules process and what was in the PBM rules that the department issued. So the PBM law provides for the promulgation of rules, and the director was required to promulgate rules necessary for implementation. Those rules had to include these specific items: fines, suspension of licenses, restriction of license, or revocation of license in accordance with the Act. So the DIF's PBM rules focus on implementation, not overexerting our authority by adding back provisions that the legislature removed during the legislative process. And the rules were subject to public comments and were before JCAR for that standard 15 session day process. The rules were confirmed by director and went into effect January 2nd of 2024. And then lastly, going to round out with a few things. So some of the guidance and actions that the department has taken since the law went into effect are: we've issued 4 bulletins. So the first informed PBMs to indicate their interest in obtaining a license in Michigan and to receive notifications related to licensure and regulations. This bulletin essentially helped give us a head start so we know who was going to apply, so we could communicate with them and clarify what those requirements were. Another bulletin instructed PBMs to submit a complete application and establish the application fee. Another bulletin provided instructions and a form for PBMs to fulfill the transparency reporting requirements. And then lastly, a bulletin we issued in 2025 reminded PBMs of their statutory disclosure obligations during investigations conducted by the department. So DIFS is statutory authorized to investigate PBMs to ascertain compliance with the Act by requiring that they provide information, data, and documents to the department when necessary. And PBMs may not refuse to produce or purport to condition the production of documents requested by DIFS under statute. And then as part of this process, DIFS also created a dedicated pharmacy benefit manager webpage, established a PBM application process, established a PBM network adequacy process, and created a consumer complaint process for PBM issues. As far as our PBM program structure, it's housed in our Office of Licensing, Investigations, and Audits, 5 specific FTEs for that area, but they are also supported by other areas of the department, like the complaint unit, enforcement potentially, in our office. And then just briefly to touch on licensure stats, before the law, we had no idea how many PBMs were even operating in the state. Post-implementation in 2024, which included the PBM licensure requirement, we now have 39 licensed PBMs. Some applications have been rejected for being incomplete, not including the necessary statutory information. Others have been withdrawn for a variety of reasons. And regarding complaints, we encourage consumers and pharmacies to first attempt to resolve their disputes directly with the PBM. If a resolution cannot be reached, our office is available to try to help resolve those disputes. We actually have a live call center answered by a real person Monday through Friday, 8 to 5 p.m. Complaints can also be submitted online through a dedicated email inbox. And if a consumer is unable to do all of those, then we will mail them that information. As of 2024, we have had 57 PBM complaints opened. And then as of 2025, there's 18 open. So a total of around 80 so far. Total recoveries since 2024 for pharmacies is $243,000. The top reasons for those complaints are fees, discount cards, steering, and then just overall reimbursement amount. So to close, a new PBM transparency report comes out this August, which will shed more insight, especially when compared to the 2024 report. You'll be able to compare those numbers side by side. We'll continue to monitor activity in the state, the federal level, and in the courts. Ultimately, if there are any issues with provisions in the law that the legislature would like to clarify or enhance, we would be available as a resource, and we would regulate those accordingly. But we encourage pharmacies, consumers, and legislators to share any issues that they're experiencing with DIFs, and we are happy to answer questions that the committee may have.
Thank you both for being here. So 39 licensed PBMs, it's 37 at time of report. 18 were exempt from reporting. Are there any other exemptions other than maybe they filed for a license but then they never did any business here, or they kind of pre-filed before they had a health plan? Were there any other exemptions allowable?
Yeah, so for example, they could be licensed as a PBM in the state. That could be a preemptive thing that they try to do to enter the market potentially. They could, but if they didn't have any Michigan-specific carriers as defined in the statute, then they were exempt from reporting. They could have done no business with state-regulated health plans. That's another potential. Or excuse me, with if they only purely did business with ERISA plans, then they would potentially be exempt from filing that transparency report as well. So it's purely statutory.
Okay. The numbers are based on self-reporting from the organizations. Is there an audit mechanism for the department if you were for some reason not trust the numbers, or is it just self-attestation?
Yeah, so it's a couple things I'll note. So essentially on the front end, it is self-attestation. Like the pharmacy would report an issue to us, or the pharmacy would report an issue to us. We could investigate that, and then if an issue is ultimately, systemic, for lack of a better term, we would trigger what's called a market conduct review of that entity, and then we could, per our authority in the law, audit them.
Okay. And then my last question has to do with the complaint process. So there's been around 80 total complaints filed. When you say complaint, can you explain what a complaint is, and that could be multiple complaints from the same pharmacy or to the same from the same pharmacy to the same PBM?
Yep, happy to characterize that. So what's considered one of these complaints is when an entity reaches out to us and asks that we act on their behalf. So if they officially request, we're requesting the department to act on your behalf, that's considered a complaint. It is a little bit individualized, where if you have a single pharmacy and all of the complaints are related to the same issue, that could potentially be categorized as one single complaint. If that same pharmacy is reporting a separate, distinct issue, that would be a separate complaint. And of course, if it's a separate pharmacy or pharmacist, that would be an individual complaint. And all of those are logged in our software that we utilize to track complaints with a single unique identified complaint number, and they're handled by a specific dedicated complaint analyst for that case.
Representative Green?
Thank you, Chair. Thank you for coming and presenting. Okay, so I'm going to expound on that complaint question a little bit. So if they go through the appeals process and it just hits a wall, can they then file a complaint?
Yeah, it's essentially they could file a complaint whenever they want to. We encourage them to try to work things out with the PBM first, but essentially that's what the complaint process is there for. If they feel like they've hit a wall, they could reach out to the department. And then it is, a novel act. We've only had it for a few years, so some of those complaints, we have to do pretty extensive research and legal research to determine what is and is not compliance with the law.
Can you just walk me through, though, so I'm had a disagreement with a PBM and I want to file a complaint, so I call, you have the hotline where a real person answers, and then what's the next step after that?
The next step after the hotline is they'll direct you to file your complaint. So that can be either email, fax, or even a paper form. So the analyst will walk them through the process of filing that complaint. Once they've reviewed the complaint, they may potentially request backup documentation to verify their perspective on what that complaint is. And then essentially the department would act as an intermediary between the pharmacy or pharmacist and the pharmacy benefit manager, essentially requiring the PBM to respond to, the allegations or the circumstances of that individualized complaint. Okay.
So just after hearing you and then hearing about you talk about the law, how it was previously passed and the changes it went through before its final passage, is there anything that we could do? Like, do you guys have suggestions on transparency, oversight, things that you see that would make the law function better?
On that, I'll say I certainly didn't come here today with a list of revisions. It's quite complicated. I think with time, we'll have a much better understanding of potentially what's working with the law and if there are any potential shortcomings. And I think at that point, we would be willing to come to the table and provide suggestions. I think at a minimum, the duplicate licensure requirement requiring PBMs to be licensed as a TPA and a PBM, that's a a big administrative lift for us, and it's not necessarily worth the squeeze, and we could dedicate those resources better elsewhere. So that's kind of a low-hanging fruit. And sort of any of the antitrust issues are really outside of our wheelhouse and the department's purview. But I'm sure there are provisions we could, if we really hammered down on a few issues, we could find.
All right, thank you.
Thank you both for your time today. We appreciate it.
Thank you.
Next up, we have Sean Stevenson from the Pharmaceutical Care Management Association. Sean, when you come up, if you just push the red button, you'll be ready to go.
Okay, well, good afternoon, Chair Bierman, or Bierlein, sorry, and members of the committee. My name's Sean Stevenson. I'm the Senior Director of State Affairs for the Pharmaceutical Care Management Association, representing this nation's pharmacy benefit managers. And I know our presentation was given to you in advance, but I appreciate the opportunity to go through that at this time. So, who's PCMA? Again, we represent the nation's America's PBMs. We have currently 20 members. I'll go through it in my slide deck a little more, but currently, as Diffs just reported, there's 39 potentially here in Michigan, but across the country, there's about 70 across the country, and some of that's based on location, a certain niche of a market that they want to administer. But what they do is they administer pharmacy benefit for over 289 million Americans throughout the entire healthcare system. So what is a PBM? We're hired by employers, unions, governments, state like the state of Michigan, and others to drive down prescription drug costs. How do we do that? One, we negotiate rebates with drug manufacturers. It was talked about a little bit in the DIS presentation, but what that really is a price concession. We work with drug manufacturers, negotiate price concessions. In exchange, they get favorable placement on formulary. We negotiate with pharmacies on driving down costs when it comes to reimbursement. We, in all that work, we save everyone who is covered by a PBM $1,154 per year. We do that through a variety of other ways as well, but one of the things that you'll hear most about PBMs is utilizing generic medications, which now represent 90% of all drugs dispensed throughout the country. So who hires a PBM? Again, private sector employers, public sector employers, commercial health carriers, government programs, and union Taft-Hartley plans. While all these entities could negotiate directly with drug companies and pay prices each pharmacy charges the general public, most choose to use a PBM because of our proven ability to drive down the cost of prescription drugs. Over the next 10 years, PBMs will save all these entities to the tune of $1.2 billion over the next 10 years. Just want to kind of go over what PBMs do and don't do. I know there's been a lot said, out in the ether, but also during the committee proceedings. So one, what we do is we secure lower costs for prescription drugs. Two, we administer the prescription drug portion of the healthcare benefit from employers and customers. And three, PBMs perform a variety of services to ensure high quality, cost-efficient delivery of prescription drugs to consumers. Finally, PBMs offer clinical services to promote adherence and ensure patients are accessing their medications. What we don't do. We don't set the list price of drugs. In this country, the drug manufacturer has 100% autonomy on setting the list price of drugs. So if a new therapeutic comes out today, that drug manufacturer would get to determine the list price of the drug, and we would negotiate down from there. So in the discussion of high drug prices, which I know is not the focus of this committee proceedings, but if the public policy objective is to lower prescription drug costs, we're going to continue to do that by getting those price concessions. But when the list price of the drug is set by the drug manufacturer, whatever price they determine is kind of where we have to start with the negotiation process. We won't allow you to take drugs that will be harmful or negatively interact with other drugs. What does that mean? You go to the pharmacy counter, independent, chain, et cetera. You go up, you say your name, your date of birth, you hand them your state ID, they scan the back, and it is in that, milliseconds that it's PBM technology that will make sure that you're getting the right prescription at the right dose at the right amount of money. And that's something that always, might get left behind, but that is the PBM technology doing that. And with that utilization management, we're not going to allow you to take a drug for the wrong reason, which does happen with some frequency, and we'll catch that error. And to prevent, it also helps prevent sometimes when a drug would be used for a wrong reason. So again, this slide just highlighting an economic report, just talking about the value of PBMs and our ability to drive down the costs. From 2007 to 2018, list brand rose 159%, while net prices only rose 60%. Rebates and Medicaid increased 40 to 70%, and from 23 to 51% for other payers. New therapeutic alternatives reduce spending. Again, competition is what works well in this market. The more competitors there are, the more options we have available to provide prescription drugs that are at a lower cost. Mail order service, you're going to hear me talk about that a little bit more. That is one method of getting prescription drugs to people that is at a significant cost reduction because of the lack of overhead that comes with the mail order facility. So PBMs impact patients by the numbers, just four numbers up here for you to consume. Again, 1 billion medication errors will be prevented in the next 10 years. I've already said the number, $1,154 per person a PBM will save on drug costs. 40 to 50% is the savings patients and payers will save on prescription drug-related medical costs without a PBM, and 440,000 PBM drug therapy and adherence in diabetes patients to reduce complications and heart attacks annually. Yeah.
How is that calculated? The savings per person, the 40 to 50%. The report that we have in Michigan doesn't tell me any of that. It just shows me how much drugs were acquired for. So how are you calculating these numbers?
In terms of the PBM value proposition,
Where do you get $1,100 per person?
$1,154.
40 to 50% savings.
yeah,
what
no,
does that compare?
I'm happy to follow you up with the sources of that. I do have that cited in my presentation, and can get that to you following this proceedings. But if you think about just in general, if you aggregate the number of lives versus someone that was going at it alone, it's all in volume. And the more that covered lives are brought at the table, the more that you're going to get a price concession out of that. So that's where the 40 to 50% would come from. Yeah. Looking at the total dollar drug spend, and again, I know it's not the public policy objective of this hearing, but important to point out that 65 cents goes back to the drug manufacturer, 25 cents goes to the pharmacy, 6 cents to the PBM, and 4 cents to the wholesaler. So again, if the objective is to drive down the cost of prescription drugs, you got to look at where 90% of that spend is. Again, PBMs are making up 6 cents of the total drug spend of a prescription drug at this time. So maybe going to that to your, Mr. Chair. Rebates and price concessions are a big part of that. Negotiating lower prices with pharmacies gets to where that $1,154 is in the 40-50%. And I can go through that right now. So how do PBMs work? Again, we secure savings through rebates with drug companies. We have mail order facilities. Again, there's another cost driver that will add to that $1,154. So I'm kind of getting at those answers right now through this slide. But again, the use of mail is significantly cheaper because it doesn't have to bake into the overhead of the brick and mortar stores. Especially pharmacies are part of the health system, and they will help save $454 million over the next 10 years. And it's because they are acquiring drugs at again, a volume that will offer price discounts. Building convenient pharmacy networks. again, when Medicare has completed and built pharmacy networks, they've saved 2% versus not. And when you're talking about billions of dollars in Medicaid program, that's real savings. Formulary management, that's just a fancy term for the prescription drugs that are covered by your health benefit plan. Claims processing, that's kind of where PBMs are born out of, processing pharmacy claims. Drug utilization review, again, we implement certain steps to ensure that if you can take a lower prescription drug, like a generic versus a name brand drug, we're going to be able to save you money at the counter, at the pharmacy counter. And then, as I spoke about disease adherence, that's some of the new items that are coming online that will allow for PBMs to ensure, like a diabetes patient is refilling their medication, checking their blood sugar levels with real-time monitoring, things that we can do to help, mitigate the disease of diabetes. So I spoke of this. The PBM marketplace is highly competitive. 73 full-service PBMs, 6 new ones coming on since 2021. And the takeaway here is there's a lot of options available to people that are looking to provide prescription drug benefits. They have a myriad of choices to look at.
On that slide,
Yeah.
with the high level of competitiveness, how's that market share look of 73 full service PBMs? Like, is there a top 5 that do the majority of the work? Is it spread out pretty evenly? What's that look like?
Yeah, no, I mean, so with only having 20 of the members, being of PCMA, I can't speak as to what the others are, but it's all, highly competitive. And, the way it typically works is if the state of Michigan, for example, in providing prescription drug benefits for their employees, want to get the best costs, they're going to put out an RFP. And entities are going to respond to the RFP. It sounds like in Michigan, there are 39. They're going to look at it, and they're going to sharpen their pencil. And they are going to put forward the best cost that they can do, provide the benefit at that point. So it'd be interested to know, how many people respond to that RFP. But at the end, with the objective being the cheapest, it would, all members and entities would have an opportunity to do so.
So there's not like 3 or 4 with 80% of the market share.
I mean, those stats are out there, yes. Yes.
Okay.
Okay. The role in the PBM drug supply chain, again, I think it's fair to review just real quick. The large takeaway I want to, have from this presentation is PBMs are not a mandated part of the drug supply chain. Employers, state governments, unions choose to use us because of our proven ability to provide savings on prescription drug costs. But if you look at where the traditional drug supply chain is, it starts with the drug manufacturer, who then uses a drug wholesaler to deliver the drugs to the pharmacy, who then delivers it to the patient. And that's the critical chain. Where do PBMs fit in? We're negotiating lower list prices from the drug manufacturers. We're negotiating with pharmacies on lower reimbursements, and we're providing that value and savings to our customers at the end of the day, which again are employers, units of government, Taft-Hartley plans. But I think there might be some confusion about where we are in the drug supply chain. PBMs never physically touch the prescription drug, so something to think about. And what often doesn't get relayed either is part of this, the wholesalers are also partaking in what is called a PSAO, and that's a Pharmacy Administrative Service Organization. And they represent, I think, 85% of all independent pharmacies and negotiate on their behalf and negotiate with the PBMs. And so on this slide, I think a lot of people believe independent pharmacies are mom and pop shops standing alone to deal with drug manufacturers and PBMs. That's not necessarily true. A lot of PBM, or a lot of pharmacies, 83% of independent pharmacies, use a PSAO to negotiate on their behalf with the drug manufacturers, with the PBMs. And I just got a chart up there to show that there is three big wholesalers or three big PSAOs in this space that also act as wholesalers, which negotiate with pharmacies on drug prices. So if we're going to have a discussion on the supply chain, I think we need to look at all actors and all entities at this point, because I heard at the testimony in the previous two committee hearings that they're take it or leave it contracts. I don't really understand that from a PBM perspective, because while some independent pharmacies will negotiate directly with PBMs, they'll use a PSAO. And I think what might get conflated is that they are talking about their PSAO and not their PBM. And I would pose that question to them as you continue this discussion and dialogue moving forward. But just have that chart up there. 75% of the contracts that are with PSAOs are with the three big companies, Cencora, Cardinal Health, and McKesson. Dispensing fee case study. Just want to bring this up. So during the first committee hearing, I screen captured the cost of dispense that the entity Pharmacists United for the Truth put up. And their definition is, in all the costs of filing a prescription, labor, workforce, compliance, rent, overhead, and supporting service, excluding the drug ingredient costs. And that's their definition. What I want you to realize is there are new players in the market. There are innovations that are coming about that happen real quickly. I talked about mail order before. When you don't have the overhead of employees, rent, whatever, as a traditional pharmacy would have versus a mail order pharmacy, that gets at the 40 to 50% savings of utilizing. You're cutting costs there because there's no overhead on that. Direct to consumer, right now you're seeing a lot of entities where drug manufacturers are doing direct to consumers. I mean, I can't turn on the TV without seeing, something from Roe or Trump RX or any entity out there that is doing prescription drugs direct to consumer, and this is evolving. So the cost on the dispense is going to differ greatly here, and to show that perspective, the state of West Virginia put on the table a $10.49 dispensing fee. And what we saw after 1 year of utilization of that, $100 million in increased costs for the same amount of prescription drugs. Finally, I want to wrap up just with a look at PBM's impact in the state of Michigan. We covered 9.3 million lives. PBMs will save Michiganders $42.3 billion over the next 10 years, and will save the Medicaid program $2.25 billion. I want to talk about a little bit, the discussion in the charge of this committee, independent pharmacy count by year, pharmacy deserts. I'm willing to have that conversation and talk about some ideas, but when you look at historically, compared to last year, there's 31 new independent pharmacy counts, and that's is sourced from NCPDP, which is the gold standard for pharmacy counts throughout the country. And as you can see, over the last 16 years, it's been pretty stagnant. And finally, with the again, at one of the presentations that happened 2 weeks ago, they put up a slide for suggested laws, and they say PUTT said tie reimbursements to floor and acquisition cost of service, enforce affiliate parity, and ban self-preferencing, strengthen audit standards, require transparency, pass-through pricing, protect patient choice and network adequacy. As DIFS went through, we do most of this already. So affiliate ban is already harnessed in 558.29. Strengthening audit standards is in 558.38. Spread pricing ban is 558.27. and network adequacy requirements are 55827. So out of all the suggestions I came forward with, I guess, the public policy discussion is about a dispensing fee, which again, I would strongly caution based on the case study that we saw in West Virginia. Finally, as Des pointed out, over the last 10 years, there's been a lot of legislation tackling the issue of PBMs as the legislature saw fit. Depending on what the public policy objective was, I don't know if it's been successful or not. But did want to point out that there are over 21 laws on the books, and I don't know, what your outcomes or next steps would be, but there is a lot on the books already. I would, strongly urge you to, push the brakes on anything further. But that's kind of where we sit today. And with that, Mr. Chairman, I appreciate your time. Happy to take any questions you have.
Let's start with the suggested laws page in your report. If maybe I heard it wrong, but I thought that DIFS just reported that those things don't come into effect until 2028. So is there a way for us to see somewhere where PBMs are already following this set of guidelines because they don't actually have to comply with it for 3 more years or 2 more years?
So the one I heard them talk about was spread ban, and just to speak on spread, so PBMs get compensated in 3 ways primarily: rebate retention, spread pricing, or an admin fee. And most of the time, depending on the payer, it'll be a machination of some of those. 2 to 3 combos, depends. So we're not going to, have any metrics on a spread ban, obviously, because that's not in effect until 2028. But the reason for the delay in that provision in particular is you have outstanding contracts that PBMs will have with various customers throughout the state, and they need to run out the time of the contract to before they start taking that out, and then onboard the new plan without the option of spread for the employers, the private businesses, and the local units of governments. So that's why there was a bit of runway for getting the bill folded in.
What's the typical contract length? Because this law was passed in 22, we're talking 28. So if you already had contracts in place in 22, I mean, are we signing 10-year contracts?
It depends. I mean, there's pros and cons to signing contracts, and it's going to be various depending on the entity that's signing the deal. Private businesses, state governments typically do it. 1 to 2 years is pretty typical and can be revisited depending on how the contract is structured by the 2 parties.
We'll go to Representative Green for a minute.
All right. I know the I'm
that's
little
all
and the
right.
big chairs are in the way. Okay. So I know a lot of what's been going on has been focused on the relationship with the independent pharmacists, but I personally have questions about that drug utilization review and like where the PBM's job, I understand why we brought them in. I guess just for clarification for my brain, like the state brought in a PBM because we need cost savings on drugs. Drugs that, I mean, they're skyrocketing. They're very high. They're very expensive. But then sometimes, though, the PBMs block access to drugs that people need, and that's through that step process. And I guess that's when you put all of these things together, there's a whole bunch of factors and layers. It's like a blossoming onion. But that's one in particular that I think my biggest beef is with this is that step process and having to go through, like I've seen it. I found the document and I meant to bring it in today, where you have to go, if you check this, you have to do this, you have to do this. If you did this, if you didn't do this, you have to do this. If you did this, you have to do this. And it's like when the doctor knows the patient best, that they just need to get to that drug, but because they can't write it dispense as written, because in some PBMs block that. Why is that? And I guess that's my my issue, is that sick people aren't always getting the drugs they need because the PBMs are a barrier in that. And I have actually talked to somebody who was an employee that was her job, was to save the company money, which of course, but then was to make it hard for them to get the drug that they actually needed to.
Yeah, and thanks, Representative Green, for the question, so I'll talk about that. Important to remember that in this country, for better or worse, employers provide their health care benefits to their employees, whether you're a private sector employee, public sector employee, union employee, et cetera. Benefit plan design is up to those entities. So if I'm working for a small business and my employer is like, look, I need to have step therapy, prior authorization in place to help me reduce costs, because if I can't keep up with the high cost of prescription drugs, I'm not going to be able to provide a benefit. And so what employers will often say is, I need these, step therapy or prior authorizations in places. So if you can go with a lesser cost drug, we want you to do that. So it's a cost containment tool for the person providing the benefits.
And I understand that. However, if they know they're going to need that, and the doctor knows that, why put somebody through that anguish to get to that point?
Yeah, and all I can say, it's based on plan design. And again, to remove the PBM from the conversation, we are third-party administrators that are simply executing the play that is called. So if your benefit design says you have to go through step therapy first before you can get the drug that your doctor says you need, that's just us saying what the employer or the person paying the bill, the payer.
So then you're telling me that then the employees or the unions can then fight with their employer to change that, not through the PBM.
Correct.
So
Absolutely.
it can become a labor issue then in a benefit negotiation.
Correct, absolutely.
Okay.
Representative McDonald.
Thank you, Mr. Chair. If you've watched the previous committee hearings, you know that one of the key things that the independent pharmacy owners testified about was that a significant share of their prescriptions are reimbursed below drug acquisition cost. They actually said that Medicaid pays better, that Medicaid is keeping them afloat by paying the actual cost of the drug or above, plus a dispensing fee. How, let's see, don't you think we should make it so in Michigan? I mean, I don't think, where do you work out of?
I live in Madison, Wisconsin, actually.
Okay, so don't
Go
you think
Packers.
it makes sense for Michigan to make sure that our small businesses are protected and that they're getting at least the value?
Yeah, thanks, and thanks for the question, Representative. So, two things on that. Is it true that pharmacists could be losing money on a reimbursement for a prescription drug? Yes, absolutely. The other half of that story, though, is drug price negotiation with the PBM, whether they use a PSAO or directly themselves with the PBM. They are agreeing to a package where they are getting a net profit. So, for example, if they lose $10 on one prescription drug that they may dispense twice a month, but make 15% on a drug that they spent 500 times a month, that overall package is going to guarantee a net profit for them. So drug negotiation isn't done drug by drug, it's an aggregate amount. So let's just say 500 drugs are negotiated at one time, and the net result of that negotiation is going to be a net profit for that pharmacist.
Until they're audited and a lot of money is clawed back later. The pharmacies were reporting that routine audits are now being rebranded as investigations so that money can be clawed back and lower their well, let me add this in my notes here. And they're clawing back money based on technical errors, especially on high dollar claims. I think someone here talked about how they only go after high dollar claims and the clawbacks because that's good profit making. So how do we put a stop to that?
And I'm just looking at, there's, so number 5 up here, there is clawback provisions. I would say, look at if that is not satisfactory to the public policy objective, maybe look and revisit that. But I will say, clawbacks are a mechanism to ensure that there's no waste, fraud, and abuse. And
I hear a lot about waste, fraud, and abuse here in Lansing right now, and often it's mistakes and errors. And when it's always going to be going after high-value pharmaceuticals because the PBM is looking to make more profit and to claw the top dollar back as possible. I'm not sure that this is about waste, fraud, and abuse. It sounds like it's about upping profits.
And I don't know the example you're citing, but let's say there's a $1,000 prescription drug and it gets billed for $1,200. We are absolutely, if the contract negotiates, it says that you only get paid $1,000. We are going to recoup that $200 if it was an error. And waste, fraud, and abuse in the healthcare system adds up quickly, and we would want to ensure that we have that tool to make sure that that cost doesn't get brought on everyone.
Can you tell me the difference between routine audits and them being rebranded as investigations? Which
I can't speak to that. I mean, I don't know that to be the case. So no.
Okay, thank you.
Sean, I have lists of questions I feel like we could probably talk about, and we could spend the day doing that, but I know we have other people that we want to get up to the table. I'm just going to I'm going to leave it with a little bit more of a statement, and then you can respond if you want to, but we have a lot of reform from 22 that hasn't fully taken effect. We're seeing reform at the federal level. We are hearing about reform in almost every state, and a lot of it has to do around spread pricing and vertical integration, and quite frankly, people being unhappy with, being forced to get, because they really feel like they're being forced to get their prescriptions through the mail. Like, it's one thing if I want to use Amazon, it's another thing if I want to go to the store and buy something.
Sure.
If we recognize through the law that some of these practices were not the right way to do business, and we're changing the law, and your clients or your association members are going to have to comply with this in just a couple of years, it seems either neglectful or willfully on purpose to continue doing it right up into the point until they have to stop. And I think that's the complaint that we're hearing, is that it's that we've recognized, and the response we continue to get back from people is, well, the law already changed. We're not allowed to do spread pricing anymore. Well, you are for 2 more years. Yeah. So I just think it's a frustration that is just built, and it's gotten worse. And now that's why we're sitting here today, is that there's that willful continuation of a policy that the state recognized was not the right way to move forward.
Yeah, and again, I think a lot of the long runway was due to some contracts that were in place at the time, but I can't speak to the reason why. I mean, to be honest, I wasn't part of PCMA when this bill was negotiated. I don't know what the discussion in the room was, why the pushback was that far back. So I really can't speak to that, but I guess I would say this. PBMs are the only entity in the drug supply chain that works to reduce costs. No one's mandated to use a PBM. A life without PBMs would be astronomical costs for anyone who's looking to provide prescription drug benefits for their employees. And I would, we're always at the table with the legislature, happy to always have discussions, and and talk about some of the public policy objectives you're trying to achieve. But we're always, going to put our best foot forward, but also, understand that the entities that are, I'll just say it, the independent pharmacists we're pulling at their bottom line. We understand that. Like, they are not our customer. Our customers are the people that are providing benefits, the private sector employers in your district, the local units of government, the Taft-Hartley union plans. Those are our customers, and we are providing those benefits, and we're going to provide them at a cost reduction because, again, we're not a mandated part of the supply chain, and all our tools that we use are to produce cost savings, because with it, there'd be really no incentive to use a PBM.
Okay, well, thank you for your time today,
you.
and we'll follow up with any other questions we have.
Thank you, Mr.
Appreciate it.
Chairman.
Next, we have John Gross. John is a pharmacy owner from Farwell and executive director of the Michigan Independent Pharmacy Association. John, I apologize for not giving you time last week, and we'll be looking forward to hearing from you right now.
And is the space bar what moves that forward? Okay. Good afternoon, Chairman Bierlein and members of the subcommittee. My name is John Gross, and I'm a pharmacist and owner of the J. Gross Pharmacy Group, which consists of 6 independent pharmacies serving rural communities in Gladwin, Clare, and Genesee counties. I'm also the founder and executive director of the Michigan Independent Pharmacy Association, MIPA, which exists to advocate for the interests of independent pharmacy owners in public policy and discussion both at the state and national level. All of the pharmacy owners you've heard in the past 2 weeks are members of MIPA. We did have several other owners that were planning to testify today, but unfortunately due to time constraints, won't be possible. Hopefully, like I mentioned, there might be an opportunity in the future. That being said, I'm very grateful to be able to have the opportunity to discuss this crucial and important issue of pharmacy closures in Michigan. I'm especially excited about the brand new House Oversight Subcommittee that was created to be able to focus on oversight areas and check state government operations like the state of Michigan's own pharmacy benefit plan that I'm going to address in a little bit. But I'd also very briefly like to mention that in addition to MIPA, I'm a member of MPA, the Michigan Pharmacists Association, and currently serve on MPA's Michigan Society of Community Pharmacists Board and also their Government Affairs Committee, where I work closely with Mr. Roth, who was in the room last week, sharing his concerns with the DIFS enforcement. And I'm also a member of NCPA, the National Community Pharmacy Association, and serve on the NCPA State Legislation and Regulation Committee, which meets to review advocacy strategy regarding state laws and regulations. And we actually have a meeting at 2 o'clock right after this is done. And lastly, I'm a proud member of American Pharmacies and currently serving a 3-year term on their board of directors. American Pharmacies serves as my buying group for drug purchasing, but more importantly, they play a vital role for pharmacy advocacy at the state and national level. And you'll be hearing from Executive Vice President and General Counsel Miguel right after me. He's an expert for defending independent pharmacy and shaping fair pro-pharmacy policy nationwide. And the reason that I mention my pharmacy affiliations is so that you'll know that in addition to my 20-plus years of pharmacy ownership, I also have extensive involvement with both state and national issues pertaining to independent pharmacies. And I hope that you will utilize my experience as both an owner and advocate as this committee and legislature move forward with embracing Michigan's pharmacy closure crisis. And over the past few weeks, you have heard some excellent testimonies and had informative discussions with PUT, MPA, and several stakeholders. But I'm here today because we are at a breaking point. And when a pharmacy closes, a community loses more than a business. It loses its most accessible healthcare provider, its primary source of medication education, and a vital pillar of local health stability. I'm here today to represent hundreds of Michigan pharmacy owners and the thousands of Michigan patients who cannot afford to lose their local pharmacy, and to work with you on the oversight that's necessary to keep our doors open. And I do want to briefly read an email that was given to me by a pharmacy owner that couldn't be here today. She was planning on it. It hits to the heart of what this is all about. Her name's Sheila Halsey. Hi, Sheila. I know she's watching right now. This is the email she sent to me last night at 10 o'clock. I've been thinking about, it's just a few thoughts on PBM issue. I've been thinking about what to say. The presenters have really covered anything I might have said if presenting earlier. And I may be one of the oldest, still working the store pharmacy owners to give input. At 75, that might be. I've been a registered pharmacist for 50 years and owned my 3 stores for 40 years. I came from a time when there was Medicaid, Blue Cross, and PCS, which was pretty new at the time. I really see no reason for PBM existence except to fleece both the pharmacies and those insurance companies not owned by the PBM. In my earlier years, the insurance companies set their own terms, processed their own claims, and paid the pharmacies. They could do that again and probably save the system all the money the PBMs are eating up. My 3 stores serve the entire middle of Montcalm County, which is just west of the geographical center of Lower Michigan. We serve Stanton, Lakeview, and Edmore, plus a large surrounding area. It is 15 to 20 miles to the nearest pharmacy, as they are all on the very fringes of the county. That puts a real hardship on the key groups of people who are not readily mobile. Please point out that our 3 stores, small stores, are regularly audited for NADAC pricing, and in the past 3 years, each store has been asked for their invoice audits. And she mentions how Obamacare has been the death knell for pharmacy in the marketplace with deeply discounted cash cards, which can be for another conversation. And how a lot of employers are purchasing plans through the marketplace, where the plans are actually utilizing discount cards instead of using their own reimbursing pharmacies through the plan. The last year DIR fees were assessed. My 3 stores had $365,000 in clawbacks, and these monies were taken on a weekly basis and includes the March true-ups, which was crazy, and that's a conversation for another time. As expected, when the 2022 law took effect in 2024, the PBMs had time to come up with a plan to shaft us yet again. As expected, they slashed reimbursements to beyond the bone. Humana, who at one time was a better payer, now pays us an average of less than $1 to maybe $2.50. Aetna is worse. Humana is the insurance that paid me 4 cents for a claim. Michigan should have the cost plus you suggested, but all companies that want to do business in Michigan must meet the criteria set, both the marketplace and Plan D. I've given my life to serve the community, or the people of my community. My savings are long gone, and I haven't had a paycheck in over 2 years. No vacation in more than 5 years. It's the only way to continue to take care of my homes, or my towns. I'm praying something will be done, and soon, to save independent pharmacy for the dedicated young pharmacists of the future. Thanks for all you do, John. Go get 'em. That was from Sheila. So, I get emotional when I read that. Mr. Bierlein, Chairman Bierlein, last week you mentioned 3 goals for these committee hearings, and the first goal is to better understand factors contributing to pharmacy closures. Secondly, understanding the role various parts of the pharmaceutical supply and reimbursement system play. And then third, to review what steps the legislature has already taken to ensure Michigan residents have access. And I heard multiple times in the past 2 weeks to keep things simple, like a second grade level simple. So here it goes for me regarding the goal to better understand factors contributing to pharmacy closures. Pharmacies close when they can't pay their bills. Pharmacies can't pay their bills when they're not properly reimbursed for the cost of their drugs and the cost to dispense those drugs. And I want to take a moment to revisit the pharmacy reimbursement model. And it was interesting what we listened to just recently, and could have a whole discussion back and forth of some of the points that were made up there. But in the pharmacy world, in order to stay in business, we have to cover 2 costs: the cost of the drug cost of the goods sold. And this is literally how much the drug costs. And the other one is the cost to dispense the drug, where we get a dispensing fee. This includes all of the costs involved to dispense the drug. If those two cost factors are covered, then the pharmacy is a break even. If the pharmacy is paid more than the sum of those two costs, it makes a net profit. If the pharmacy is paid less than the sum of those costs, then the pharmacy will lose money on that prescription fill. So how do you determine what those costs are? Well, the cost of the drug is easy to figure out. You look at the invoice and see what you paid for the drug. But the cost to dispense is more complicated to figure out. And the most recent national cost to dispense study that I could find was released in 2020 using 2018 data. And this is showing as of March 26th by the different entities that put this together that the average acquisition cost was, results show the overall cost to dispense was $12.40 per prescription. Now, Michigan conducted a cost to dispense study. In fact, over 10 years ago, the Affordable Care Act and CMS mandated that any state that receives federal dollars for the Medicaid programs must conduct a cost to dispense study to determine how much it actually costs a pharmacy to dispense one prescription. Michigan was required to use their cost to dispense study results to pay pharmacies a defined reimbursement for their fee-for-service Medicaid claims. And by April 1st of 2017, MDHHS was required to reimburse pharmacies at NADAC plus 1064. Previously, reimbursement was based on MAC, which is a subjective price that is determined by the PBM at any point in time, plus a couple dollars. But today, independent pharmacies are reimbursed one of the 4 dispensing fees listed, depending on the classification of the drug. Typically, in my experience, the most commons are the preferred medications for $10.80 and the non-PDL medications for $10.64. But notice in this slide from CMS that was giving the final rule out back in 2016 that the intent was to create a fair pharmacy reimbursement system. The final CMS rule is designed to ensure that pharmacy reimbursement is aligned with the acquisition cost of drugs and that the state pays an appropriate professional dispensing fee. Unfortunately, what happened is that there was an exception. Reimbursement and managed care organizations, the Medicaid managed care plans, were exempt from that reimbursement methodology. And I experienced this back in 2017. It was the beginning of my understanding how the whole thing worked. Medicaid managed care plans, Molina's, Meridian's, Blue Cross Complete, Upper Peninsula Health Plans, they're the plans that are when you're on Medicaid. And in Clare County, where I'm at, we're about 35% Medicaid. They're the ones that process the prescriptions or handle the medications. So, for example, I have a Medicaid patient in Clare County. They have to choose a Medicaid plan. It could be Molina was pretty popular in our area. And incidentally, with just me and Walgreens in Clare, and Molina is not accepted by Walgreens, I get all of the Molina patients. But when we fill a prescription for Molina, I went down in 2017 to ask, I had filled 800 prescriptions and made a total of $800 in profit. And I called up Molina to ask for a copy of my contract because I couldn't find it. And I didn't realize that I didn't have one with Molina. Actually, they used a pharmacy benefit manager, which was Caremark. And so I did have a contract with Caremark. It was a take it or leave it. And it was at that moment that I realized that I was getting paid that $10.64 for fee-for-service claims, but not for the Medicare managed Medicare claims. So Michigan is a hybrid state where if I was to bill a claim in my pharmacy for a medication on the formulary, it'll go through on the managed care plan through Caremark for Molina or Meridian. But if it's a carved out medication, for example, a lot of the anti-anxieties, anti-psychotics, antidepressants, if we billed Caremark for that plan, it would tell us to bill fee-for-service, the straight Medicaid plan, which incidentally, the state Medicaid plan fee-for-service uses a different PBM, which currently is Prime Therapeutics, which ironically is being sued by the Attorney General along with Express Scripts. So in the pharmacy area, a Medicaid patient comes in, we could be billing two different insurance companies, their fee-for-service or their Medicaid managed care plan. But when this first came out in 2017, the managed care plans were exempt from that methodology. You can go back and find on Facebook a post where I put the rantings of a disgruntled pharmacy owner where I got paid 16 cents for a claim that I filled, where the PBM paid me 1 penny and the dispensing fee was 15 cents. And from that, I had to make all my payments. And fast forwarding from that, what ended up happening was working with the legislature to get boilerplate language that would have the Medicaid plans pay what the fee-for-service plans paid. And that's how that got set up a few years ago and recently was codified with the Medicaid bill that now forces the Medicaid plans to reimburse pharmacies the same as the fee-for-service Medicaid reimbursement. And that's, if you have any questions or clarification on that, I'd be happy to go over with that at a different time.
John, can I get you to pick like one more thing you want to
Yep.
point out so that Miguel has a couple minutes to?
I will.
Thank
I'm
you.
going to go straight to the state Medicaid, or the state, your insurance plan, the state legislators, the state's plan. So I'm going to have to fast forward through that. Here's that DIFS report that they pulled up earlier where it shows the fees that were retained and the $150 million that was retained by PBMs. The FTC, United States House Committee on Oversight, talking about PBMs. Right here, here's a MIPSR contract. This is a pooling of over 100 independent pharmacies in Michigan, showing a timeline from October 24 to February 26. And it shows the average NADAC difference. And what that means is, NADAC being the cost of the drug, back in October 2024, pharmacies, this pharmacy group was averaging $10.32 above the cost of the drug. And it went up in in November, and it went up in December. And then in January of 25, it dropped to 83 cents. So the cost of the drug and the cost to dispense was showing a profit of 83 cents. This prompted last year for me to go see my state representative, and ultimately I think we had a meeting with a couple of representatives, and we brought in the Michigan Department of Budget and Management, who procures this contract. And we shared with them the concern that this slide was presenting. And here's another look at it right here. Because it was fleecing pharmacies, and we were not getting, we were kind of the same thing as with the Medicaid, as we were going out of business by getting underpaid for these state plans. And the reason that I want to pull this up is that unlike other plans, that commercial plans and payers, and that this particular plan is procured by the state of Michigan. You guys, the state of Michigan, have chosen this plan and the payout and the setup that it is, and the effect that it's having on independent pharmacies. Here's the actual contract, so it's all available online. The scope of it, the $1.4 billion that was added on December the 3rd to the contract. Notice at the bottom there, though, dispensing fees. Typically 80 cents per net paid claim for certain retail tiers, with 0 for home deliveries and 0 for 90-day retails. I handed out packets last week that showed these plans. One of them was 200 and some prescriptions that the total amount paid was $2 or less. There's the MIPSR plan, and there's the state of Michigan plan. And so,
John, we have 2 minutes of committee left before I have to adjourn.
okay. Seems to be my plate when I come down here. So,
I am sorry.
Well, I appreciate the time to get to talk, and I would greatly encourage having an outside of the Oversight Subcommittee meeting to be able to further share the things I have to share in the time spent.
Thank you very much for your time today, and we'll set something up. Miguel, you want to say hi, or? Our final testifier is Miguel Rodriguez, Executive Vice President and General Counsel with American Pharmacies. Fire away for a brief minute.
Yes, sir. I'll give you the 1-minute version. And I submitted written testimony, so you'll have the benefit of my full testimony in the record. I just want to go over a few things. There's been a ton of consolidation in this market. There are only really 3 big players in this market. That's Optum, Aetna, and Express Scripts. They control the majority of the market. But what I think was left out in the earlier testimony was an important thing. Not only do these companies control 80% of every prescription drug claim, but they all also control 42% of every pharmacy claim. These PBMs own the largest pharmacies in the country. So half of every prescription dollar spent is spent at one of their pharmacies. That puts these entities in direct competition with independent pharmacies like Mr. Gross, and it gives them an incentive to do tactics to increase their pharmacy business to the detriment of their competitor. Effectively, the PBM acts as a referee, but they also own one of the teams on the floor. And so they have every incentive to help that team win. All the tactics that we've been talking about, primarily reimbursement, are going toward, under reimbursement, are going toward eliminating their pharmacy. In fact, in the state of Michigan, Optum, one of the biggest PBMs.
I have to cut you off. I'm sorry. By our rules, Representative Green moves to excuse absent members. There being no objection, the motion prevails. There being no further business before the committee will stand adjourned.